Assalamu alaikum. I hope you're all doing fine. I am Dr. Muhammad Ali Rabbani, and today we are going to discuss in detail the different functional areas of the cerebral cortex, the functional localization, and we will try to enumerate the different cortical areas in the four major lobes, the functions of each of these lobes. We will correlate the lesions of these areas with the symptoms thus produced, differentiate between primary and association areas in the sensory cortex, and elaborate the concept of cerebral asymmetry when there is connection between the two hemispheres is lost. So that we will discuss. So let's before we start, let me tell you this is our lecture in a series of lectures of neuroanatomy. You can find all these lectures on our YouTube channel. Just explore and go ahead, and don't forget to follow and subscribe to get the recent updates. So this is a picture from BRS neuroanatomy. So it has shown different areas, anatomical localized areas, and those are demarcated by different Brodmann's area. Brodmann was a scientist who was the first one to give each area a specific numerical value based upon the particular histological appearance it had. So these are the different Brodmann's areas. We will be looking at the most frequent one, and like the frontal cortex and primary motor, premotor, and so on. So this picture can be taken as for reference. I will go on explain each of these as I move along the lecture. So let's start with the frontal lobe. If you have not, do follow the lecture of cross anatomy of the exterior of the brain. In that lecture we have discussed all the sulci and gyri. So if you look from that, the frontal lobe overall it consists of all the area that is in front of the central sulcus. So all this is the frontal area. First, let's talk about the precentral area. This is the area that consists of this precentral gyrus, and this is the central sulcus, its anterior wall. If you look from the depth, precentral gyrus extending onto the medial surface, and this part of the horizontal gyri, this posterior part of the horizontal gyri, there is the superior and this is the inferior frontal gyri, sulci, and superior, middle, and inferior frontal gyri. So this whole area that is particularly involved in the motor function, that is the pre-central cortex. We will shortly divide it into primary and and association areas and pre-central areas. So histologically, that is not the topic of our lecture here. I will be shortly uploading the lecture on the histology of the cerebral cortex. But for a quick reference, the cerebral cortex gray matter is consisting of 6 layers from the surface, starting from molecular layer to the depth to plexiform layer. And between them, there are alternating pyramidal and granular layers. Layer 2 pyramidal, 3 granular, and then internal pyramidal, internal granular. So in all the areas that are motor in functions, the pyramidal cells, those are prominently present, and granular cells, those are absent. So the these motor areas will have absence of granular layers and the prominence of pyramidal layers. And especially in the primary motor area, there is the largest pyramidal cells presents, the pyramidal cells of beds that that sends the signals down the corticospinal tract to the fibers or cells that are responsible for the most discrete skilled movements. By the way, the name pyramidal tract is not due to these cells, but due to the medulla oblongata pyramid. So let's start with our first area. This is the primary motor area. This is the primary motor area. Where it is located? It is located on the anterior aspect of the central sulcus. You cannot very much see here, but this is the central sulcus. If you are able to pass your fingers within the central sulcus, the anterior aspect of your fingers will touch the posterior aspect of the precentral gyrus. That's what they are talking about here. Precentral gyrus itself, And if you go on to the medial aspect, you will see this part. This is the anterior part of the paracentral lobule. This is the paracentral lobule, this U shape. This is the central sulcus. This whole is paracentral lobule, and this demarcated line, this is the anterior aspect of the paracentral lobule. So here it is located. The layer 3 and layer 5, the external pyramidal layer and internal pyramidal layer, are very much prominent in this, and the layer 2 and layer 4, the granular layers, are not so much. Its function is the final station for the conversion of design into execution. In front you have frontal cortex. You think there the premotor cortex. We will shortly see where all of these schemas are made, and you can give an analogy of a very big keyboard. Like, the primary motor area consists of all the different buttons, and each button is responsible for one particular movement. For example, this will be responsible for flexion of the thumb to a particular degree. Someone would be responsible for flexion of index finger and pronation and supination. All the movements that you can name, there is a particular button of this. This part, this primary motor area, M1, it does not think for itself, it does not make judgment, it just executes the design that it is given. So even if during a surgery a person is awake, even if not awake, you, with the electrode, you just give stimulus to a particular part, you just give stimulus at here, then the part that is connected to this particular part of the cerebral cortex, this primary motor cortex, this will show movement. So this is the point where the corticospinal tract starts. This is the point where the pyramidal cells are present, whose axons are making the corticospinal tracts. For the upper limbs and lower limbs, for the limbs, they are responsible for the contralateral movements of limbs. And for the cranials, for the corticobulbar tracts, it is responsible for bilateral movements. Exceptions are lower half of the face, superior rectus muscle sply, genioglossus muscle sply. We have discussed that in detail in brainstem. By the way, that lecture is available online. Now, if you try and meticulously figure out which point serves which area, you will eventually make a map of the body on the surface. Like, this area will supply the oral cavity and tongue. This area will supply the different muscles of the face and hand and trunk and legs and foot. So this whole map, this somatotrophic representation of the body, this is called motor homunculus. This is called motor homunculus, and location may vary from person to person, but general map, general sequence is usually constant. And you can see the parts of the body are disproportionately represented. So much area is given to the face as compared to whole of the leg. More area is given to the face as compared to the whole of the leg. This proportion is that the areas, the more fine control you have over that part of the body, the more representation area you have in the primary motor cortex. You can make so much facial expressions, excitement, anxiety, fear, and whatnot. So face has been given a large area. You have very fine discrete functions on your hand, your thumb, your index finger. So that is a given area. On the back, you don't need that much finesse. On the foot, you don't need that much. So those areas are given lesser representation. We will discuss that in the lectures about the arterial supply, roughly the way or of the medial aspect and some part of the lateral aspect. So this part is supplied by anterior cerebral artery, and all the rest of the area that we see right here, this is supplied by middle cerebral artery. So this relation with the cerebral arteries comes in very handy in clinical setting when you are discussing a cerebral infarct. A cerebral infarct involving the anterior cerebral artery will lead to the non-functioning of these areas, the part that is supplying the lower trunk and the lower limb. However, the lesion of the middle cerebral artery, it will lead to the loss of function of the muscles of upper limb and head and neck. If there is bilateral case, then head and neck, but still. So this was a very, I like this picture very much, the artistic representation of the motor homunculus. We will see this picture with primary sensory area, but you can see so much area is dedicated to hand as compared to the limbs, upper and lower, and so much area is given to the face and especially lips and tongues, because that are involved in your fine skills, that is your speaking. If that part is damaged, if primary motor area is damaged, it will lead to contralateral upper motor neuron type paralysis. So, because this is responsible for the supplying of the contralateral limbs. So, contralateral muscles which supply will damage, and the function of the corticospinal tract was majorly to conduct a discrete movement in the distal musculature. So, those will be most affected. Yes, there will be some still functioning of the proximal musculature of the upper limb and lower limb despite the damage of the cerebral cortex, because those are also supplied by the lower areas like vestibular nucleus, red nucleus, and so on. So the other tracks, the non-pyramidal tracks, may lead to the movement of the proximal musculature, but the distal, the functional musculature, that is the most seriously affected. Right here in the paracentral, in the medial aspect, in the paracentral lobule are the areas that are responsible for the sphincters of anal canal, the sphincters of bladder. So injury to that lead to the bilateral injury, lead to the incontinence of the urinary system, of the digestive system. The corticospinal in itself, in alone, the pyramidal tract alone, if damaged, it does not lead to the spastic paralysis, because the spasm is usually produced to the damage of the extrapyramidal tracts, and usually the lesions that are below the cerebral cortex influence other tracts beside the pyramidal tracts. Therefore, you usually see spasm in the upper motor neuron type lesion, but that's not the case when there is a pure lesion of the pyramidal tract. Again, this topic is discussed in very much detail in our lecture of lesions of spinal cord. If any particular part of the brain is damaged, that part will become non-functional. If that part is excited, that part will start showing movement, and that is Jacksonian epileptic seizures. Any irritative lesion or irritative insult, maybe it may be a tissue scar or infection or worm or anything. If any irritated thing, it starts probing, or it starts release of the signal at particular point of the primary motor cortex, that part will start showing epileptic seizures or movement. So that's called Jacksonian epilepsy. And as it goes on, as more and more areas are involved, the more areas will show convulsions. And if whole of the brain is involved, then it is due to this primary motor area that you actually see the whole body convulsing, because as the wave goes through whole of the brain, that is the part, the primary motor area, that is responsible for contraction or movement of the whole of the muscles of the body. Let us move on to the next segment, the premotor area. This motor area is denoted by Brodmann's area number 6, number 8, number 44, number 45. All of these areas are involved in premotor areas. So technically speaking, they are present on the anterior aspect of the precentral gyrus or precentral sulcus, or posterior aspect of precentral gyrus. If you just push your hand through the precentral sulcus, the anterior aspect will touch, your fingers will touch the posterior aspect of precentral gyrus. So it's present right here, the whole of the precentral sulcus, and then there are three horizontal gyri, this superior, middle, and inferior frontal gyri. The posterior aspect of these will be included here too. So this area contains the pyramidal cells, but not so much. So there are no giant pyramidal cells of pets, and its function is to store the program of motor activity, or the store the sequence of motor activity assembled as a result of past experience. You think of any simplest task, just it may be as simple as scratching your nose. Can you see how many movements made that possible? My shoulder was flexed, my elbow was flexed, wrist was flexed, it was a little pronated, my these fingers were flexed, and this flexion extension alternatingly that occurred, and that led to my scratching of the nose. And that's a very simple example. Think about something as complex as speaking, as complex as driving or playing FIFA on your joystick. So this sequence of movements, now we have to do this, now this, now this, now this, now this. So this sequence of movement that you have gradually learned over time, this is your learned activities, that is your learned programs, that is stored in the premotor cortex, that is responsible for premotor cortex. And premotor cortex itself does not send any signals down below through the cortical spinal tract. It sends, but that's not responsible for movement. The premotor cortex use this program, it store these in its memory and send the signal one by one to the primary motor cortex. So it's like an operator that's typing very fastly on the primary motor cortex keyboard. So it will lead to now this, now this, now move this, now move this, and so on. You will do your learned activities, comb your hair, you will tie your laces, you will drive your car, and you can think of anything on this aspect. So programming of intended movements. I have not differentiated secondary motor area from premotor area. If you go into the detail, the secondary motor area, it's a little different, but let's, for the argument's sake here, let's keep them common right here. And especially through the secondary motor area, cause postural movements of the axial musculature and such tones, these are maintained through this area too. If this particular part is damaged, you will not have any paralysis. The person will be able to move the limbs because the primary motor area is still functional. However, the fact is the learned activities, the programmed activities, so those will be affected. So that is called apraxia, inability to do, inability to execute the learned or skilled motor movements. There is no weakness. The person is unable to do that in a correct sequence. The person may even forget, or the person may not even understand how to do things. You asked him to comb the hair, he or she may pick up something else like a toothbrush. They may not know how to use the comb properly. That may be placed in opposite direction, and the person will not be able to drive now, the person will not be able to tie his laces now, and so on. The list can go on. So that is called apraxia, inability to do learned activities. And do differentiate it from paralysis because the person is still able to move both the limbs. And most of the stored activities are, they are present in the dominant area. And in for most of the cases, for the rest of the lecture, I will consider left side the dominant hemisphere. So if the program is stored in the left premotor area, it has to cross the midline and then activate the primary motor area on the right side if you want to move your left hand. So sympathetic apraxia means even a person with left side infarct, left side premotor area damage may not be able to do learned activities from non-dominant hand. Even the premotor area of the non-dominant hemisphere, that was the right, was okay. That is the sympathetic apraxia because most of the programs are stored in the dominant hemisphere. If there is a combined lesion of 4, that is the primary motor, the pre and the primary, 4 and 6, that is the premotor area, if there's both are damaged, then there is a spastic paralysis as compared to complete paralysis as compared to the lesion of the primary motor area alone. There is a worse paralysis if both these areas are involved. But again, there is no paralysis if only premotor area is involved. Then the next region that I want to talk about is frontal eye field. Frontal eye field is present in the middle frontal gyrus. That is the superior and this is the inferior frontal gyrus. It is present on the posterior aspect of the middle frontal gyrus, and it is responsible for conjugate movement of eyes to the opposite side. So let's say you wanted to see on the right side. The frontal eye field on the left side will send signal down that will cross the midline. In the pons, it will activate parapontine reticular formation, and parapontine reticular formation will lead to the activation of the abducent nerve nucleus on the same side and oculomotor nerve nucleus on the opposite side. By the way, going to the opposite side through medial longitudinal fasciculus, and through that both the eyes will look towards the right side. So left frontal eye field is responsible for moving both the eyes to the right, conjugate movement towards the contralateral aspect. And there is a similar eye field area present in the occipital lobe that is called the occipital eye field, but you have to differentiate it from that. The frontal eye field is responsible for voluntary movement. So I want to look here, there. You are looking at the slides. You want to look at the text and then the picture. So all of these movements are through frontal eye field. But have you ever experienced that sometimes you're just lying down and you're relaxing, and in the sky you just see some bird going through and your eyes are fixated on it? You're just lying there, you're just relaxing, and a person moves in front of you, and you just track that person going from side to side. Your friend asks, why are you looking at her like keenly? You said, oh, I was looking at her, I don't know. So if something is prominent in a background, your eyes automatically fixate to it. So that involuntary tracking is through occipital eye field. So in the case of lesion of frontal eye field, the involuntary tracking remains okay, but consciously, willingly, that person is unable to move the eyes towards the contralateral aspect. And that is why at rest, the eyes will be pushed by the healthy side. A person had a lesion of the right frontal eye field cannot move the eyes towards the left, and at rest the left eye field baseline signal will deviate the eyes towards the right side because it is not being balanced by the opposite hemisphere. Next is the motor speech area. I will discuss just the area here. I'll go through the different speech abnormalities in a separate segment in the end of this lecture. This is present somewhere here, Broca's area. So it constitutes the area 44 and 45. It is part that is present in the inferior frontal gyrus, and you can consider it as the premotor area for speech. This area, I will just give you a very brief overview as I am going to discuss this in detail later on. Here is a vernix area. This is the Brodmann's area. This is the area that is responsible for language. So if you want to say someone hello, the word hello is generated right here. And this signal is sent to the arcuate fasciculus through the Broca's area, and that language that is translated into a series of muscular activities here in the Broca's. If you can see, something as simple as saying hello involves your diaphragm muscle, your chest wall muscles, your larynx, all the muscles will be vocal cords, your pharynx muscles, your palate, your tongue, your lips, your jaw, your facial expressions even. So all of these muscles, these are being controlled by this plan is being given by Broca's area, and then the Broca's area pushes on the button of the primary motor cortex one by one to execute all that. So if that area is becoming non-functional, the person will know what to say. The person will be able to make sense, but the person will not be able to speak fluently because depending upon the extent of damage, more than a few steps cannot be stored depending A person can be saying a few words at a time, or one word at a time, a few syllables at a time, or not at all, depending upon how extensive Broca's has been damaged. Last but not the least, in the frontal cortex is the prefrontal cortex, all the areas that remains in front of it. This is the part that makes you human, and it has numerous connections, especially with the dorsomedial nucleus of thalamus and the different areas. So its function is all the higher mental functions: your intellect, your emotions, your mapping, your personality, your depth of thinking, your logical reasoning, initiation judgments. All of these are through prefrontal cortex. The prefrontal cortex was understood, the function of the prefrontal cortex was understood when this man, the Phineas Gage, underwent a drastic traumatic injury. What happens is that he was a foreman in an American railway working near, I think, Vancouver, not Vancouver, working near Vermont, I think. And he was a railway worker, and he was responsible for placing the he was responsible for placing explosive charges for removing the mountains while making a pathway for railway track. So his job included drilling holes into the mountain, placing explosive material, pushing that explosive material in with a rod, and then blasting that area and removing the debris so that the railway track can be made. So what happens was, one day he just drilled a hole, he placed explosive there, and then he forgot to put sand in that mixture, and that made that material very unstable. So when he was just like in by the rod, he was pressing this explosive material, compacting that material down. He made a mistake of making his face in front of it, and due to the wrongly made mixture, that material exploded unexpectedly, and that rod, it shot up like a missile, and he had his mouth open. He was talking to a colleague. It went through here, as you can see from the lateral aspect of his face below the zygomatic arch, through the orbit, behind the orbit, through the prefrontal cortex, and up through the skull. And that's where it all went. And something, anyone who had witnessed that thought that, how can this person survive? But what happened was, he walked around, he walked to the place, sat down, and he called for a doctor. He told what he was problem. He did not even become unconscious. The rod was shot up with such explosive force that it fell about 80 meters apart, and he did not even become unconscious. And when he told the doctor what happened, he did not believe that he must be making things up, but he saw that that really had happened, and that person is still up and running and talking. And then he had a long recovery. He became worse over a period of time. About 10 weeks later, he was discharged. There was, during this his hospital stay, he had complication. His eye had to be removed, and there was fungal infection and so on. But what happened was, the important thing is what happened when he came back to life after work. Before the accident, he was considered as an excellent worker, and he was a favorite of a lot of his colleagues and his um, seniors and so on. But after that, the people said that he's not the person that went to the hospital. He was an ideal person, he was a good friend, he was a reliable person, but he was not that anymore. And he become short-tempered, he become emotionally distant, lost his ability to think critically, lost his ability to plan ahead, and was fitful, he was very openly profane now. He give profanity speech, and impatient, or and there are so many other issues. His personality overall changed. So then they understood that this was the point in the neurosciences where they understood that has the frontal art cortex has all these functions. By the way, I have added this QR code. You can just go to the Wikipedia page and read that in detail. And it continued to astonish neuroscientists for a long period of time. They even exhumed his body after his death, and his skull is still preserved in a museum. So, frontal lobe syndrome, Phineas Gage syndrome, leads to inappropriate social behavior, cannot concentrate, lack of initiative, foresight, perspective, adaptation, emotionally distant, apathy. There is abulia, and there is slow speech. By the way, Phineas Gage had that when during his hospital speech, he would not give answer for more than one syllable, one word, when very strongly probed. Childhood reflexes came back. Infantile suckling reflex, Gaps reflex, catapraxia, incontinence, and mutism. Sometimes that happens too. And another example I can give you is if you have seen a movie Shutter Island. By the way, it's a very nice movie. And here you can see those high priority criminals, those extremely violent criminals, were given frontal lobotomies, and that was a very prominent and regular procedure during 50s and 60s. That frontal lobe prefrontal cortex was cut, and it was passed through the cribriform plate, and this frontal lobe was cut, and the person developed all these stuck features, and he was no longer menace to the society. And that especially occurred when after World War II the Western world was against the death penalties, and but still they deemed a person too um, violent or too dangerous for the society, so they did frontal lobotomies, so that produced frontal lobe syndrome. So that is all about the frontal lobe.